Hello. On behalf of Canon Medical Systems Europe, welcome to day 3 already of our online cardiology days. Today we're going to focus on structural heart disease. We are very proud to have again a fantastic faculty ready to share their experiences with you. So, with that, it's my honor to introduce the moderator for tonight, Professor Ole de Backer. Professor de Backer is a very famous interventional cardiologist working at Rigshospitalet in Copenhagen. And it's actually very hard to find a major international study on structural heart interventions in which he has not been involved. So, Professor de Backer, thank you for joining us, and I'll hand over the session to you.
No, Joanne, thank you for this very nice introduction. Well, indeed, welcome to everybody on this third day of the online cardiology days organized by Canon. And this day will be spent on structural heart disease and what the role can be of imaging. So I'm really honored to have a very expert panel here. Let me introduce first Professor Michael Zuber. He will give a presentation on the implementation of modern ultrasounds in clinical practice. Next, we have my colleague, Professor Klaus Kofoed, who will go a little bit deeper into the role of the expanding role of CT in structural heart disease. And finally, we have a talk by Dr. Asami from all the way from Japan on optimizing structural heart disease interventions and then towards minimally invasive treatment. So first, I will introduce Professor Michael Zuber. He will be the first speaker. He's a senior consultant in cardiology at the Hospital of Aarau and a professor in cardiology at the University Hospital of Basel. And he's not just the first cardiologist we found on the street. He actually introduced TOE in Switzerland in 1988, then stress echo, 3D echocardiography, and he was also actively involved in introducing interventional echocardiography. So we are really honored and we look forward to the talk by Professor Zuber.
So thank you very much, Professor de Backer, for this kind introduction. For me, it's a pleasure to share with you a typical case of my clinical practice from structural heart disease and to show you the implementation of modern ultrasound into a real clinical practice. So this is my conflict of interest. Now this patient is 50 years old. He was sent from a GP for cardiac evaluation because of exercise intolerance since 1 year, no CID risk factors. In the clinics, you can see it's not an ideal candidate for transthoracic echocardiography because 190 centimeter high and 107 kilo in weight is not an ideal candidate. But the blood pressure is normal, and you see left ventricle is abnormal palpable, and we here in the auscultation a 3/6 holosystolic murmur. So let's just go to the echocardiography. You see on the left side a 4-chamber view, apical, and on the right side a 3-chamber view. And of course, everybody can see that we have an enlarged left ventricle, a huge left atrium, a normal function of the right and probably of the left ventricle, and we see an enlargement of the annulus of the mitral valve, and we see a prolapsing P2 and possibly a flail of the chorda. And if we want to see much better, we take the right side and we zoom it. So this is a picture. You don't need a TE for doing that. And now you see everything what you need to know. We see that this P2 is prolapsing. We see even a small caudal flail at that. We see a small calcification of the annulus. We see a mitral annulus disjunction as a sign of arrhythmic possibility. And this is a 2-chamber view. If we take the 3-dimensional probe, you can see that at the same time we can use the X-plane and we see both at one time, the apical 4-chamber and the 2-chamber view. And again, you see this pathology of this mitral valve that is a typical P2 prolapse. Now, that's not all if you take the 3D volume, because you can add another plane and you see all 3 planes that are very necessary to evaluate this mitral valve in the same time. So that's a real advantage, and you can shorten up the evaluation. One click, and you can add the 3 morphology appearance of this valve and of this whole ventricle and this whole heart. You can see the the prolapsing part. You can see this small caudal flail. You can see the trabeculations in the left ventricle in one click. And if you want to see it better, you zoom it. And now clearly you can see this flail, you can see this small caudal rupture, and this is really done from the transthoracic approach. Now that's not all. If you have this 3D data set, you can move it and rotate, and you can have the double volume at the same time. And you can see on the left side at the bottom from the left atrium, the prolapsing part that is going up to you. It's a surgical view of this valve. On the other side, you see it from the left ventricle. So it's only one click and you get everything ready. Now let's go to the zoom of this picture, and then you can clearly see the pathology of this mitral valve. You see the P2 prolapse now in the surgical view. On the left side, you see the left atrial appendage. On the other side, you see the aortic valve. And this is done from the transthoracic approach. Now, advanced echocardiograph means that you can also do more. Look at that. You take the true view, and this delineates the structures even much better than if you take only the normal view. Appearance is here much better. And you can also change the light source. You can go with the light more deep in the left ventricle, and now you clearly see what the surgeon perhaps will interested be, because this P2 flail is large and it's prolapsing really into the left atrium. When you discuss that with the possible other colleagues, you can go and look on the valve. You can register it from both sides, from the left and the right, from the anterior and the posterior. Now this is a unique possibility to describe and to show you results and discuss it with other people and even with surgical people. Now that's the picture that you end up. It's a transthoracic picture 3D. You see the P2 flail on the lateral side and on the medial side. So remember this picture for the further presentation. Now that's not all. That was the morphology of the valve. Now we need the functional pathology of the valve. You see this huge eccentric jet going along the interseptal wall, ending up in the pulmonary veins. Then you go to the quantification of that. You change the baseline, and then you can really nicely show the pre-acceleration, and the radius is really huge. The PISA is huge. And if you take also the CW Doppler, you can measure the effective origin of this valve and also the regurgent flow that is huge. So we have the quantification of this valve. Now that was with the 2D probe, but you can also take the 3D probe and you have the same in one view. The X plane of the 4-chamber and the 2-chamber with a color Doppler. That's really nice, but not all. You can push it one click and then you see the 3D morphology of this regurgent jet ending up in the pulmonary veins. If you take this data set, you can take other views that is very important. For example, this view, you are looking on the valve from the left ventricle side, and you see that we have a huge effective regurgent orifice in the middle of the valve. You can stop it and you can measure that. So really ideal to follow up the patients and to make the diagnosis of a severe mitral insufficiency, all in a 3D data set. So that's not all. We need also to know about the function of the of this structure of the left ventricle. You see now the automatic analysis of the ejection fraction, normal ejection fraction, end-diastolic is elevated. As you can see, you get these results by one click. And also you get the global longitudinal strain in one click. It seems to be normal in the apical 4-chamber view. But if you take the 3D data set, look at that, then you can press and you get the global longitudinal function, not only from the left ventricle, but also from the left atrium, from the right ventricle, from the right atrium, and even all these curves you can really delineate from your 3D data set. So this advanced echocardiography makes you very fast in evaluating the patient. Now, if we that all together, we have to decide which treatment for this man. Should he go for another follow-up with 6 months to do nothing? Should we go for surgery with reconstruction? Should we go for interventional reconstruction with clipping and all these different possibilities that we have, small, large, Pascal mitral clip, or should we go for a valve replacement, transapical, transseptal? First, we have to decide that we have a primary mitral regurgitation that is severe. And I have showed you everything. We have a flail leaflet in the mitral morphology. In the collar jet, we have a large eccentric wall impinging jet. We have in the flow convergent a large throughout systolic jet. We have a continuous wave Doppler jet. We have in a semi-quantitative wave, we have a vena contracta that is huge. We have the pulmonary vein reflow. We have in the quantitative approach a huge effective regurgent orifice area and a huge regurgent volume. And I showed you also a large left ventricle and left atrium. So with that, we should go to the new guidelines of the management of valvular heart disease published in European Heart Journal of this year. We have a patient with symptoms. We have a patient with normal ejection fraction, and then we should go to surgery if repair is possible. So to know that, we also have to use the CT, for example, to show the coronary morphology. In this patient, we had some plaques, but no stenosis. So at the end, we have a low area score of 0.5. And of course, this man should go to surgery whenever possible. We went to that with all these measurements and these pictures, not doing a TE. And we went to Professor Maisano. He is a follower and successor of Professor Alfieri in Milano now. And he did a surgical reconstruction, a minimal invasive with a small incision and with an annular band and a P2 resection. So remember my picture that I have shown you from transthoracic 3D. This is the P2 flail, and I show you the effective morphology when we did the surgical approach. You see now, this is the flail leaflet. You see the small caudal rupture at the end of this leaflet. So remember and see what is really great. You can show that from transthoracic approach. So this was at the end. You see the ring, you see the P2 resection, and of course, you want to know the result. So I show you the result, 1 year of follow-up of this patient, again, simply with this 4-chamber view. You see that the left ventricle is going smaller, the left atrium is smaller. You see the bright spots that are the band that was implemented, and you see that the valve is opening very nicely. In the color Doppler, you see no obstruction and only a minimal insufficiency jet that is not relevant. And if you take the short axis at the annular base, so you can see this annular band, really it's fixed. And in the middle, you see the valve, and with color, you see on the lateral side a minimal rest insufficiency. So we are very happy, and not we, also the patient is very happy. So let me go and make the conclusions that advanced ultrasound techniques should be implemented into daily clinical practice because they changed from a research tool into a routine tool. And even advanced echocardiography, I showed you, can replace transesophageal echocardiography in some patients, what is a key element in heart interventions today. Thank you very much.
Well, thank you, Professor Zuber, for this excellent presentation. And this was really a very nice illustration of how echocardiography is really very important in not only diagnosing, but also preparing for a procedure. And nowadays, also for many transcatheter treatments intraprocedurally, it's also very important to guide these procedures, how echocardiography has a very important role there. So let me introduce to then next my colleague and friend, Professor Klaus Kofoed. He's a famous cardiologist here and in Denmark, and he's also a director of the Cardiac CT Research Unit. He has really comprehensive clinical and research experience in the field of cardiac imaging, including cardiac CT, PET, and echocardiography as well. So Klaus, please go ahead.
Great, thank you to be here. It's an honor to be here. And I guess for this presentation, the term structural heart disease is kind of somewhat broader than what most cardiologists consider. And just to ease the focus or get you to understand what you will hear about in the next 15 minutes, I've made this overview. So first, briefly on some of the CT technology that kind of paves the way for new ways of thinking of using CT. So these are the three different approaches that you can record CT, and then the topics of structural heart disease that I will just briefly cover and give you an impression on where the CT technology may be moving in terms of expanding into areas of structural heart disease that may not be that well known. So going to the CT technology, the most recent or the most used approach is the so-called prospective approach, where you just start recording in the late diastole. And the reason for using that initially was that that was giving us a very low radiation dose. But now you are actually able to do full retrospective imaging, which means that you have recorded image information in the whole RR cycle, and therefore you can have actually images that describes the functional diastole systole sequence of the heart. And this actually now has developed into a routine here at RIX. So we always do that because there's no reason why we shouldn't, because the radiation dose is so low and it allows us to do a lot of more interesting things. And even more advanced is this new approach of doing multiple beat, so-called dynamic cardiac CT, where you are able to record a sequence of images following the injection of contrast. And that allows you to draw a curve on how the contrast arrives within the vasculature and how it's taken up or extracted by the myocardium. So this was, of course, mainly developed for assessment or quantitation of a myocardial perfusion, but as it turns out, it may also be helpful for structural heart disease. So going back to the old approach, or actually the most widely used approach, the so-called static CT, where you do just one prospective scan. As it turns out, this very detailed structural delineation of the heart have revealed a lot of morphology variations that may or may not be significant for cardiomyopathy. And here are two of the examples where you can see on the top you have these so-called crypts, and you can also delineate the what is called trabeculation. And does it make sense, or is it important to appreciate these differences? Well, we looked at that in our population study, the Copenhagen General Population Study in 10,000 healthy people. And as it turns out, it's actually good to have crypts, whereas if you don't have any crypts, it may not be that good. It's kind of surprising because crypts are actually considered as something that might indicate that you have a cardiomyopathy. But in our data, we couldn't see that that was actually any problem to have that. Probably it's a normal variation. Completely opposed to that is that if you do have a large extent of hypertuberculation in these 10,000 individuals, it appeared that that was actually predictive of having a high risk of death. So these are two examples of structural heart disease that you may appreciate when you do CT. Of course, of more general interest, I could suggest is that, of course, the left atrial appendage occlusion, which has now been tested also in the surgical setting. It was really ingenious and fantastic that this recent study in the New England Journal of Medicine demonstrated that on top of anticoagulation, it appears that occluding the left atrial appendage, that actually protects against stroke. Of course, the procedure has already been developed percutaneously, and so it was just very nice to see that this was actually also helpful for patients undergoing surgery. But turning back to the role of CT in particularly left atrial appendage occlusion, This has, of course, already been partly written into the recommendations that you, of course, it's not explicitly mentioned that CT is what you should do, but I think the general consensus is that CT is really essential for sizing before you decide on what type of device you want. During procedure, it's not that helpful. You can't do it during procedure, but after the procedure, of course, you can use it for assessing the leakage and the position of the occlusion device. And I have a few examples here. Of course, this is what it looks like before and after it's been placed here. And this, of course, is not successful, or not so successful, because you can see that there's contrast in the auricle. It may be that this is an early test, so that at later points this will kind of be resolved. But it just shows you what you may get out of doing a CT after after the procedure. Another approach that may be helpful is, of course, it rarely you see complications after the procedure, but you may have some hemorrhage after this, and you can, of course, understand that if this is the pulmonary artery, and sometimes when you see during a functional CT here, you can understand that sometimes there might be some leakage here, but of course it's very rare. I'm just showing this to illustrate what the possible value of doing the functional CT after such a procedure. Okay, this is, of course, I have to put this in the presentation because this was an ingenious idea by our moderator, Dr. De Backer, where he suggested that we did CT before the procedure, did a 3D printing, did a bench testing where these small beads was put in there, and on fluoro you could see to what extent that particular size of the device would suit and make sure that there wouldn't be any leakage, and that was actually a really ingenious idea. I guess that was the starting point for using very widely the CT approach for these kind of procedures. And of course, here, sometimes you see that it looks fine. Well, I'm sorry, that came out wrongly. Most of the time we see that this looks very good, and we see a complete occlusion. You don't see any contrast on that side. So moving to another area where structural imaging with CT might be helpful. This is actually kind of rare case, but you can always appreciate that there's actually a rupture of the left ventricle. This patient had a recent MI and they weren't recovering, and nobody could really understand why. And so we did the CT and found this, and patient underwent surgery and actually recovered very nicely after that. Of course, the big thing that could be in structural heart disease, of course, the assessment of valve function. And I'm sure many of you are familiar with this, where you can actually assess how the TAVI valve is functioning. Of course, it requires a diagnostic screen to be able to see this, but just for presentation, I put this normal valve in here. What can happen, and that was has been of some interest for some time, is that in some patients you actually see that there is a stiff and enlarged leaflet here in the TAVI valve that might or might not have implications clinically. So far, it's considered to be a benign finding, but it's not really fully resolved what the implication of such a finding might be. But this is one of the most important accomplishments of structural CT in recent years, that you are actually able to image such kind of valve function, which is somewhat difficult even with echocardiography. A new area, of course, is evolving. We're all looking for when the right device for this more complex valve of the mitral regurg will be coming. But one of the things that will really taking off is that also CT may have some important implications for identifying patients in whom it would be helpful to do percutaneous treatment of valve dysfunction. And here are some examples of where this has been, reviewed. One of the more recent ideas would be that we could actually, by this functional CT, segment the mitral valve and then have a lot of measures on what this, of course, is a normal valve, but this is ongoing work, and we think that that would be very interesting to pursue further. For just to give you an idea of what the dynamic imaging of CT, I mean, the sequence over time might do. This is a very rare case of a 56-year-old man with chest pain, and this is just a standard CT where you can see the left main. And you may appreciate that there is a right coronary artery, but somehow it doesn't seem to be connected to the aortic valve, sorry, to the aorta. And therefore we did this dynamic, and I apologize, it's kind of slow, but what you can see here pointed out is that this is the pulmonary artery, and this patient actually had an abnormal right coronary artery, which was coming from the pulmonary artery. And what you see here is there's a retrograde flow back to the pulmonary artery. And this is something that's very difficult to visualize invasively, but here it's actually not that difficult if you do it with a multiple beat dynamic CT angiography. So moving on to, well, maybe this example is even more complex, but just do it really quickly. This is a patient with a baffle where you have this is a subpulmonary ventricle and the subaortic ventricle, and this patient had a baffle leak, and you will see it here. And that was actually the only way this could be visualized using a dynamic CT. I'm in short of time, I'll just move on. The last topic I want to take through with you is, of course, the transcatheter pulmonary valve implantation, which has also been expanding in patients with grown-up congenital heart disease. And there you see that the CT is actually becoming the test for planning for a sizing of the pulmonary valve to figure out the delineation of the branches of pulmonary arteries. And of course, also to figure out what is the vicinity of the coronary is when you consider doing a dilatation of the pulmonary ostium. You need to know, and many of these patients actually have quite abnormal coronary anatomy. You need to know what is the relationship between the annulus and the coronaries. And so this is become a routine approach for planning any of the pulmonary valve implantations that we're doing here at RIGS, that they always have a CT before that. So I guess the take-home messages here is that clinical utilization of cardiac CT imaging has expanded from initially only ischemic heart disease to structural heart disease. Simple imaging logistics, high imaging quality, and very low radiation dose allows for detailed and anatomical assessment of left ventricular contractile function, heart valve function, and function in patients with a broad range of structural heart disease. So I think it's fair to say that we haven't seen the end of where a CT may have clinical value, especially within the field of structural heart disease. So yeah, thank you for your attention.
Thank you, Klaus. Really great, very nice images also, and very nice illustration of how CT is applied in cardiology and in preparing for structural heart disease interventions. And I can only confirm that I'm a pure structural heart interventionalist, and I really count so much on Klaus's services. I mean, I use CT basically for all my procedures to prepare, also to follow up sometimes if there's suspicion of like leaflet thrombosis. Let's say in TAVI and LAA closure or preparing TEVAR, I cannot go without the CTs from Klaus. So it just shows how essential CT is in the field of structural heart disease. I cannot emphasize more. So Klaus, stay tuned because we're going to go for the question at the end. So now let's move to the last speaker, which is Dr. Asami. He's the chief physician and he's an interventional cardiologist at the Department of Cardiology at the Mitsui Memorial Hospital in Tokyo, in Japan. So it's really an honor that you are here, even in the middle of the night in Japan. It's really great that you do this effort. And Dr. Asami, he's actually also specialized in structural heart disease. He spent time in Switzerland for this, and now he's back in Tokyo. And there he specialized in the structural heart disease, which is a collection of heart disease that include valvular heart disease, but also heart failure, hypertrophic cardiomyopathy, and congenital heart disease. And in the presentation of today, he will, the title of his presentation will be Optimizing Structural Heart Disease Interventions towards Minimally Invasive Treatment. So Dr. Asami, please go ahead.
Okay, thank you, Professor De Becker, for your kind introduction. So good evening, ladies and gentlemen. Thank you all very much for joining this exciting webinar sponsored by Canon Medical System today. So I'm Masahiko Asami from Mitsui Memorial Hospital, Tokyo, Japan. So I'm delighted to be here today to tell you about optimizing structural heart disease intervention. This is my COI slide. So my talk is divided into just two parts. So I start with talking about latest evidence of TAVI, and then I will share one of most tough case in my life with you all. So as you know, there has already reported several evidences about TAVI. And then in operable patient, extremely high surgical risk, both balloon and self-expandable valves showed much better clinical outcomes compared to patients who treated by conservative treatment. And then furthermore, in patients with high surgical risk, 5-year mortality in TAVI is comparable with that in surgical AVL. And then in the same line, in patients with intermediate surgical risk, TAVI with balloon and self-expandable valves showed similar outcomes compared with surgical AVL. Then recently, in patients with low surgical risk, TAVI using balloon expandable valves showed superiority about 2-year composite outcomes consisting death, stroke, or early hospitalization compared with surgical AVL. And then self-expanding valves showed numerically lower incidence of 2-year composite outcomes consisting death or disabling stroke compared with surgical AVL, but not reaching statistical differences. However, I think that 2 years are not enough long to evaluate clinical outcomes in patients with low surgical risk due to their younger age. But in Notion 1 trial, 6-year outcomes in low-risk patients undergoing TAVI has already been investigated. There were no significant difference in 6-year all-cause mortality between TAVI and the surgical AVL. And then meta-analysis of these 7 RCTs were conducted. 2-year mortality was prior to TAVI. It showed 12% relative risk reduction up to 2 years. In addition, focusing on transfemoral approach, it showed 70% relative risk reduction up to 2 years. So now new ESC guideline for the management of valvular heart disease is available. So as you can see in this slide, TAVI is recommended in several situations. So I'm focusing on its age and surgical risk and heredity. Age should be over 75 years old, and the surgical risk should be STS or Eurosquare 2 over 8%. If anatomy is suitable for TAVI, I would strongly recommend TF TAVI in those patients. So let's move on case review. So an 87-year-old male with symptomatic severe aortic stenosis was referred to me in order to consider TAVI. He had a progressive dyspnea on exertion, and his symptoms were worsening during the last few weeks. But his lifestyle was still active and independent. And then you can see his risk factors and comorbidity in the upper slide of this slide. And he had a hepatocellular carcinoma treated by TACE and RFA. And he also has a state of acute prostate cancer. And then acute subdural hematoma was occurred and treated by craniotomy for drainage of hematoma. After that, he had angina treated by POBA in order to avoid taking antibiotic agent Lyclone. Now I will show you coronary angiography afterwards. And he underwent open abdominal surgery using Y-graft for abdominal aortic aneurysm. And I think in his past medical history, this is very important to perform TAVI. And SDS score was 6.2 or 2%, critical quality scale was 4. Here you can see laboratory data. He had a good renal and liver function, but he had a high NT-proBNP level and a slightly low hemoglobin level. The EKG at the baseline showed normal sinusism with heart rate 67 beats per minute. SDS depletion be 5 to 6 and frequent PVC were observed. This slide shows echocardiographic assessments. Severe aortic stenosis with Vmax 4.7 meter per second, mean pressure gradient and 59 millimeter mercury, ABA 0.6 square centimeter. Words are observed. Here, normal LV and RV function, normal pulmonary hypertension was shown, and a moderate aortic regurgitation was also observed. Significant stenosis was shown at distal RCA and circumflex, and yeah, here it's POBA site. It looks stenosis, but it was no change compared with previous angiography, and the LAD was intact. This is multi-site CT scan before TAVI. Diameter of ST junction and SOB were enough big to implant transcatheter heart valve, and LVOT had no calcium, no horizontal aorta, and coronary heights were 70.1 and 40.0 millimeter. I didn't think that coronary protection was not necessary. And the maximum and the minimum diameter of aortic valve annulus were 22.2 and 28.5 millimeter per meter, and the area were 79.4 millimeter and 489.0 square millimeter. The calcium ball was much higher with 790 cubic millimeter. Both femoral arteries could be used for TAVI. However, terminal aorta below renal artery at surgical site showed severe tortuosity. And then right side image comes from operative note. And then this is renal artery, and this is internal iliac arteries. So from here to here, artificial blood vessel exists. So in summary, patient in 87-year-old male with symptomatic severe aortic stenosis, aortic valve complex showed that its perimeter and area were 79.4 millimeter and 489.0 square millimeter. He had a state of post-Y-grafting at terminal aorta with severe tortuosity. He was severe heredity due to hepatocellular carcinoma, prostate cancer, and acute subdural hematoma. So therefore, our heart team decision was to perform TFW from right femoral artery under general anesthesia. And then SAPIEN 3 26 millimeter reducing 160 from nominal pressure was selected, and a pigtail delivered from light radial, and then temporary pacemaker insert from light jugular vein. This is arthrography to decide perpendicular view. I have performed VAV using 23 millimeter Edwards balloon, and I also checked arthrography during VAV in order to determine valve size and how much inflation we need. And then this is I tried to insert 14 phalanges, but it is not advanced at the location of tortuous artery. And then the wire changed from Safari 2 to Landakis, which is stiffer wire. Again, it did not work. And then I pushed the Cs too much. Yeah, maybe now. So you can see ACs was broken. Yeah, now here, yeah. And then I changed ECs to 20 French dry seal. And then, yeah, I was not able to pass it to just point even in dry seal. And then my colleague pushed his abdomen from left side to prevent advancing force of the cyst from escaping to his left side. And then if we choose local anesthesia and sedation, this technique could not select due to heart pain. I put in a cylinder a bit and push cyst. I mean, I was doing a push and a pull technique, and then I advanced the cyst fully. I inserted transcatheter heart valve, but it was stuck at the proximal edge of artificial blood vessel here. Then I delivered a wire and a 6mm balloon from left lateral artery to this point. And then during balloon inflation, balloon advanced a bit, but it did not pass. Then so I did a strip through technique like PCI, and then it did work. However, the delivery system might be broken. Therefore, the valve was not able to mount optimal position of the balloon. You can see here. So it's, we are not able to retrieve the valve here. So that's why I try to implant the valve even in this system. So we inflate the balloon slowly with rapid pacing. But the balloon slipped to LV without properly expanding the valve. I put the balloon, but I could not. Yeah. And then I tried to inflate again, but it again slipped to LV. At that time, rapid pacing was too long, so I put the balloon strongly, taking a risk, and then unfortunately, valve came out from the aortic position. And then I confirmed the orthography and the T eclipse. I saw the aortic artery was too large to implant this valve. And a CT scan before TAVI revealed the optimal position to implant this valve. As I mentioned before, his arch was too large. And the descending aorta was also large except for the location of artificial blood vessel here. But a linear artery may be occluded. So, okay, here. Might be deployed above. So we also check the T to measure the outer size. It may be implanted optimally. And then put the valve to T location while inflating the balloon like this. Yeah, and the balloon inflated fully, but the valve was not expanded due to inadequate position of the balloon. Then I determined to use snare in order to put the valve to optimal position of the balloon. Then I try to hold the valve, and then I lock the valve by the snare and then pull the valve, and then move to this position to optimal position. And then based on TU measurement, I related the balloon adding 1 cc to nominal pressure. I saw that long C is enough to exceed the position of the valve. I implanted that the descending aorta was necessary. And then first I changed the wire from the Safari 2 to Landkist, and then changed the Cs from 20 French dry seal to 22 long dry seal. The C successfully advanced while putting his abdomen, but I had lost my concentration. Yeah, you can see there. the cyst pushed up the bulb to the edge. And then I checked the orthography. The bulb was not properly attached on the wall, so I thought that we should put the bulb again. And then I tried to deliver a colder balloon, which is a bigger balloon, to the upper side of the bulb. However, stiff wire located on the edge of the bulb, so therefore the balloon did not pass the bulb. And then again, I thought the snare would be helpful. The snare cuts around the kissed wire and push down it. Now I will push the wire like this. And then here you can see T-clip wire load. I mean, it came to the center of the bulb. The colder balloon advanced to the upper side of the bulb successfully, and then a balloon was inflated and put down the bulb with heartbeat together. Then I inserted in a cylinder carefully and then advanced the seed slowly and carefully, like this. Then I prepared the new Sapiens 326mm bulb with reducing 1 cc from nominal pressure. As you can see, a bulb mount optimal position of the balloon. We implanted the bulb at the optimal position. This is a final confirmation. Looks like good to me. I also performed autography just in case, descending outer and including artificial blood vessel did not have any injuries. So the patient stayed at the intensive care unit just 1 day. After that, he moved to general ward and stayed there for 6 days. He discharged 7 days after TAVI. It's normal course in our institution, so it means he had no extended his planned hospital stay for even in just 1 day. So finally, I would like to introduce our cath lab system. We have 2 cath labs and hybrid operation rooms. We use Canon products for all. And then why did we choose Canon system? So for cath lab 1, we select 8-inch flat panel. For cath lab 2, we select 12-inch flat panel. Then in cath lab 1, catheter ablation and PCI are performed. In cath lab 2, mainly structural heart disease and endovascular treatment were performed. But 12-inch flat panel is easy to use and can perform all procedures, including PCI. As I told you, 12-inch flat panel is easy to use, so can perform SHD, EP, and vascular stroke, and even PCI. I mean, good to use even when you want to see small vessel like this. So, ladies and gentlemen, this is a take-home message from myself. So, TF-TAVI should be primarily recommended based on favorable outcome in previous literatures. Pre-TAVI CT and intraoperative TE should be fully assessed in complicated case. And the general anesthesia may be sometimes associated with less invasive therapy compared with local anesthesia and sedation. The snare technique should be acquired for minimally invasive therapy. And then Canon angio system is great, I think. Thank you for your attention.
Thank you, Dr. Azami, for this presentation and also sharing this heroic procedure with us. That's great. I think we have great material now to take some discussion following these presentations about echo, CT, and then also the structural heart interventions. So please, I would like to invite all panelists to join this and open up their camera to join the Q&A. I have had, in the meantime, a look at these Q&A and these questions. And let me start first with Professor Zuber. He has been had to wait the longest time after his presentation. So I saw a question coming in about the 3D and the complexity sometimes of using 3D. So 3D TEE, I also know from my experience when I'm doing MitraClip or TriClip that I really need an experienced echocardiographer who really has experience to do swiftly these, go to these views, have a surgical view, 3D options. So can you comment something on this, how complex it is, how you can become better? What's your advice there or recommendation?
What I showed you is a transthoracic approach. So even there, it is not a simple procedure. We have to exercise. We have to do it in every patient. So you get exercised also in difficult patients. Otherwise, you can show only in one good patient. As I have shown to you, I took really a difficult patient who was obese. So to show that it is possible to do 3D transthoracic even in not ideal candidates. But what you mentioned is the interventional 3D. Of course, I did a lot of intervention together with Francesca Maisano all the time. And there it is very, very important that not somebody is going to do the interventional proctoring who has no experience. So there you should need the best that you have. Otherwise, you will not be really happy with that. I saw sometimes they send people who has not done a lot of interventional echocardiography, and so the interventionalist is totally at the end. He cannot do anything. Mm-hmm. So, for my advice is you have to do a lot of cases, and you have to be experienced cardiologist to do interventional echocardiography 3D. And this you cannot do when you have done 20 patients. You need more.
Okay, I agree on that. And then also, if we make a jump then to Dr. Assami's presentation, where he says we have to go minimal invasive. How do you see that in echo? Like in my lab, we have started to use over the last few years a lot of intracardiac echo also to try to keep these structural heart procedures really minimally invasive, without general anesthesia, really slick. So can you share some experience there, like ICE for intracardiac echo, for PFO closure or LA closure, or maybe other procedures?
You wanted a discussion from my side or
yeah, from
okay,
Dr.
yes, of course. We used ICE in university hospital then when we have not ideal visualization with 3D transthoracic echo. For example, in TriClip, or if we have difficult mitral clip procedures, then we add an ICE, but not doing the whole procedure with ICE. With ICE, you have a really good delineation of what you want to see exactly at the point. For example, when we did a lot of cardioband also with ICE, but only at the end when you want to see really what's happening. But for the overview, we always need 3D.
Yeah, I also fully agree on that. I mean, ICE is a good tool for guidance during the procedure, but you cannot count on it for your 3D visualization or your real true measurements. And that's also, if we use, for example, ICE to guide our LA closures, we really fully trust on the CT scan or the 3D TEE measurements we have, and in our center now CT. So indeed, I think that's an important point. ICE is a nice tool, but it's mainly to guide, and it's not so much to get the real full 3D. It's very hard to get a full 3D overview, yes, indeed. Then Klaus, there were a few technical questions in the Q&A which I cannot answer on CT. So there was one question about what kind of CT you need. Are you talking about 64, 128, 256, or even more slice? Can you comment a little bit on that? I'm not an expert in that field.
Sure. I guess it depends on what type of scan you want to do. I can just state that we actually have the 320 slice scanner. I mean, for many of these procedures, and translating that means that the coverage of the heart, you can do that in one beat. So you have 16 centimeters of visualization in just one rotation, and of course that is probably required for if you want to have meaningful dynamic CT. I think you need that. If you want to do just functional full IR interval, you can do that with smaller coverage, but again, it all depends on what your experience is, and the more coverage you have, I guess, as a rule of thumb, the easier it is to obtain these high quality images that we are able to do with equipment that we work with.
Mm-hmm. And can I have you show these very nice images of 4D-CT showing leaflet thickening, etc. And of course, that needs several series. Should we be concerned there about radiation? What is a kind of a radiation exposure there for these patients?
Well, that's a good question, and I think at the time when we did this work, you and I together with a lot of other people, the radiation dose was substantially higher than the current newest equipment that we have, and now. I don't think that for this type of patient, doing a full RR cycle to assess the functional status of a TAVI valve, that's not really an issue anymore. You can repeat that multiple times and still you will still be on the safe side of what is reasonable for a radiation dose. Of course, you can't do it in young people. I mean, multiple. You can do it in a couple of times in young people, but if it's older people, just like the target patients for TAVI, then I don't think it's any issue, the radiation, to do multiple testing of this.
Okay. And then I saw a question from Elvira coming in. She asks, do you get additional information from dynamic perfusion protocols in comparison to static perfusion? And how can it influence the treatment? Can you comment?
That's actually ongoing. Or when we talk perfusion here, the main target for that is kind of off the topic of this webinar, but that's myocardial perfusion imaging. And I think one of the main things that, I mean, we use the perfusion for myocardial assessment routinely now, and one of the main things about dynamic is it's much easier to interpret. You don't need, I mean, and the reason for that is that you get multiple images where you're able to delineate much more clearly what is ischemic and what is not ischemic. If you use a static approach, which we also have worked with, that's very demanding for the reader, and I would think that it's not as robust as the dynamic approach. So this is why I think we should go that direction. But this is off the topic of structural heart disease, I would say.
Okay. And then there's more a comment from Claire Griffiths. She says, I'm working in a pediatric center and we found that the advancements in CT, specifically for congenital defects, has resulted in a reduction in the number of patients undergoing diagnostic catheterization. She asked if we see a similar tendency. I can not have an answer on that one, but I can imagine that indeed CT, I mean, CT contributes also a lot in the diagnosis and the assessment of these congenital patients. Yes.
I guess again, this is a topic for the next week's webinar. But for now, I guess what we see is that whereas going back 2 years or so, we actually almost never did CT on infants, but now we do at least once a week. We have a case, and most of these cases are very complex, and it's not rare that it's combined with invasive cath, because we actually contribute to the understanding of these complex cases in a sense that we cannot do by invasive. So it's not either or. I think in many of the cases we do both to ensure the highest security for when the patient undergoes surgery, that any potential abnormality has been described in detail. So that's kind of the direction that we are moving here at RICS.
Yeah. Okay, thank you, Klaus. Dr. Azami, I also want, before you continue your night in Japan, I have some questions for you. I mean, you show very nice how important CT is also in your pre-procedural planning, especially of that TAVI there too, not only for the cardiac CT part, but also for the access. Just from my personal point of view, did you consider alternative access, because that's one of the points, that if you have great imaging pre-procedurally, you could have maybe foreseen that it would have been almost an impossible or risky undertaking to cross these iliofemoral arteries. So maybe you could have gone transaxillary or another alternative access. Did you consider this?
Yes, of course. Thank you. In this case, we check the subclavian artery and carotid artery, and then, of course, direct aorta is also possible. And then, as you know, femoral access is a much better outcomes compared with the alternative access. So that's why we always think about femoral access as our first line approach. So that's why in this case, we know this is a tough case, but yeah, we select the femoral approach.
Okay. And then there's an interesting question from Ron van den Broek. He asked, what is playing the role of continuous invasive hemodynamic monitoring during structural heart disease interventions? And I think it's a good question. It's both for TAVI or for MitraClip. How can you, does it play a role there, or because indeed, if you go for very minimal approach for TAVI, sometimes we do not use TEE as we did in the beginning, where we had all patients in general anesthesia with TEE, checking for maybe some leak, etc. So now sometimes we trust on aortography. We also trust a lot on hemodynamic measurements. Can you comment on this? How does it play a role in your clinic for during TAVI, but also during MitraClip, for example?
Thank you. So in TAVI procedure, we always check the invasive hemodynamic after valve implantation. And then we check the residual aortic pressure, mean pressure gradient. And then if it's acceptable, we termination of the TAVI procedure. But if still they had still pressure gradient, we will perform post dilatation. And then in MitraClip, we always check the LA pressure during procedure. And then if LA pressure becomes decreasing, we will deploy the valve at that point.
Yeah, I can also comment or add on that too. During MitraClip, indeed, in the newest J4 generation 4 MitraClip, actually, if we talk about that specific product then, but it's also applicable to other products, you have indeed a continuous pressure measurement in the left atrium, because that's where you are with your device trying to clip these leaflets of the mitral valve. So indeed, if you have the continuous hemodynamic pressure measurement, we look to the V wave in the left atrium. And indeed, when we have a successful clipping before releasing the clip, we typically see a good drop in the V wave. So that confirms that we have a good reduction of the mitral regurg. If we do not see a nice reduction in that V wave, then probably we're going to reposition our clip. So indeed, it plays a role there. It also plays a role in TAVI, I would say. We measure really nice the pressure in the aorta and the LV before TAVI. We also compare it and afterwards, of course, we see complete immediate disappearance of the gradient, but we also use the end-diastolic separation between the LV and aorta before and after TAVI to see if there is some signal of PVL, of paravalvular leak. So indeed, it was a very nice question. I think hemodynamics is also playing really an important role in structural heart disease interventions. So I would like to ask Professor Zuber, Professor Klaus, Kofu, Dr. Asami, do you have some more questions for each other maybe before concluding this nice webinar?
Yeah, perhaps I can add something. We have seen beautiful cases from the CT. I only want to add that all these cases I would diagnose with echocardiography and not with TE.
And of course, the responses I would tend to agree are not entirely, because some of them you cannot actually. I'm also an echo person, and some of them you do not have the opportunity to have the full image of the entire vasculature and the myocardium and the valves, But of course, many of the patients that we look at, you start with echo, and that doesn't change with these new technologies that CT provides.
I think indeed they're very complementary. I mean, in my daily practice, being a structural heart interventionalist, I'm relying both on echo, on CT, but very often they're very complementary, and I cannot without any of those. Echo is very important for the diagnosis, CT really for my real meticulous pre-procedural planning, knowing which device size, etc., which position I have to do. And even there's our applications coming up, and that's now and today already, where we have computational simulations. We can use the CT images, and we have computational modeling of our devices in that CT. So Klaus also knows we have a project on this. So it has a lot of applications, and this is also really the future. But Echo is, of course, really, we cannot miss it. Also during procedure, for some procedures like mitral tricuspid, it's essential to guide us through these cases in a safe way and in a successful way. So, and I think Dr. Azami really showed nicely where this field of structural heart disease is going. It's going to a minimal invasive, really sober, slick approach. And that's where we're heading to. So I think it was a very nice webinar. We touched upon a lot of topics. Of course, we could talk many more hours on this, but I think we would like to conclude this webinar here, and I give the word back.
Thank you very much, Professor De Backer, for moderating tonight. So indeed, we'd like to thank all of the faculty for great lectures, great discussions tonight. And for now, thank you all for joining, and see you next week. Good night.